name is Julia. Um, I am a current pharmacy resident at North Country Healthcare, and I am excited to talk with you all today and this part of your diabetes session and talk more in depth about medications that we can use in diabetes. Before I begin, I just wanted to make this like an interactive kind of presentation and make sure that you all can get something from it that you're interested in. So I was wondering before I begin if anyone in the audience has any particular questions or wanted me to kind of focus in on a specific topic. Let me know before I begin so I can kind of like cater my presentation towards your interests and any medications in particular. And that's okay. If you don't have any specific things that you're interested in right now, I'll still be pausing and stopping for any questions throughout the presentation. So if you do think of any questions later, feel free to stop me or just call out your questions and we can go over that. I can try to answer that to the best of my ability.
I do one question as
Yeah.
I w- one I would kind of like to know more about also for me and like for our participants might be like Ozempic.
Okay.
Uh,
Yeah, definitely. Okay, I'll write that down.
Thank you.
Yeah. Yeah, that's definitely something we'll go over later in the section because I know that's a big medication right now, very popular out in the news and social media. So yes, we would definitely go over that one. Anyone else? Anyone else have any specific interests or questions they have before we get started?
Hi, really quickly, I think most of the people that we see in our clinic that I'm aware of, a lot of them are on metformin. So maybe just spending a little bit more time on metformin and breaking down like how it works in the body and things like that.
Okay, sounds good. All right, thank you for that. And yeah, if anyone has any other questions, feel free, you can just stop me and ask questions, and I'll try to remember to pause and ask questions throughout as well. Okay, so so starting off, I'm just gonna go over a broad like treatment overview, just kind of looking at all the things we think about when looking at diabetes and how we treat it. So today we're going to be focusing on the medications, but just wanted to give a brief overview, which I think you guys have already gone over in a previous session regarding like lifestyle management and modifications and how we can bring down our blood sugars like more naturally through our diet and exercise. So that's something and another great tool that we can use to help bring down our blood sugars along with medications if we do need them. So for today's session, we're just going to be focusing on the medications in particular. We're going to be going over our oral medications, for example, like metformin, glipizide, Ozempic, etc. And then we're going to be going over insulin as well. We're going to be going over the different types of insulin and how they work to bring down our blood sugars in the body. And then one other session that you may have already gone over, but just to kind of tie everything together. So with our medications and how we can kind of monitor how they're working for each patient is looking at either our A1C test or our daily finger sticks. And just to summarize, our A1C test is a test that your doctor would order usually every time you come, a patient would come into the clinic. And it measures your average blood sugar levels over the past 2 to 3 months to kind of see where they've been. And so that's a test that your doctor would normally order. And then we also have our finger sticks where we would use our blood sugar meters and our test strips and check our blood sugars on a day-to-day basis to see how they're doing and how these medications that we're going to be talking about, how they are affecting our blood sugar. So it's always important to monitor our blood sugars while on these medications to see, how they're helping and if we need to change anything or modify any medications to make sure patients are at goal. Alrighty, so I just wanted to highlight here that over the past few years, the guidelines for diabetes has been changing over time. And so now how we kind of go about choosing our medications is we kind of look at other disease states or other conditions that the patient may have at that time. So besides diabetes, we also look if patients have cardiovascular disease, if they have kidney disease, or if they have heart failure. And if someone has one of these conditions or more than one, then we may want to choose certain medications that benefit not only their diabetes and lowering their blood sugars, but it can also have some benefit on these three conditions as well, which we'll get into later on for each specific drug class. So that's kind of the broad overview of how your doctor, your clinician may choose or may decide on what medications to start first, because usually we try to pick the medications that have the best like bang for your buck and not only helps diabetes, but can also help these other conditions as well. So that's kind of like the brief overview of how we may first choose a medication. I also wanted to go over in this bottom section here. Sometimes there are some instances where we may just start patients on a long-acting insulin. And this may be because, insulin is one of the most effective medications we have to help bring down our blood sugars in a short amount of time. So this can happen, if somebody is newly diagnosed with diabetes and they come into the clinic, if their blood sugars are 300 or above, if their A1C is 10% or higher, or if they have other symptoms of high blood sugar, like they're feeling very thirsty, they're using the bathroom a lot. Those are some reasons why we may just start somebody on insulin to begin with. And it may just be a temporary medication we put somebody on just to help bring those blood sugars down faster so they start to feel better quicker. And then we may just transition them to different oral medications. But that's another instance if somebody has a very high blood sugar, we want it bringing down quickly, they're having symptoms, insulin is probably the best option for us to start with to help them feel better faster. Alrighty, so I'm going to start talking about our non-insulin medications, and I'm going to start off with metformin to begin with. Before I get into metformin, does anyone have any like experiences or different thoughts or perceptions about metformin that they would want to share with everyone? Or if somebody has been on metformin personally and want to share their story?
I have a comment. This is Adeline. Um, I I have a friend who works at Zuni IHS, and she says that the physicians there are of the mindset that whether or not you test for diabetes, I mean, it's not borderline. They said if you have diabetes, you have diabetes. They don't consider borderline as borderline. It's if you're borderline, you have diabetes. And so what they recommend is for the patients to get on metformin and then that enables the patient to regulate their sugars and helps them lose weight. And I don't know if that's sometime a method used by some physicians or clinics.
Okay. Are you talking about like starting metformin before they have like a diagnosis of diabetes? Is that what you're talking about?
Or before they have, I know this isn't the correct term, but like full-blown diabetes where you know you're you're dependent upon insulin.
Okay. Um, yeah, I think what you may be talking about, and correct me if I'm wrong, is sometimes, before somebody is diagnosed with diabetes, and that's, when their A1C is over 6.5%. Um, there's this period before then called like pre-diabetes, and that's when, your blood sugars are elevated, but not quite the diagnosis of diabetes. And so sometimes doctors will start patients on metformin before their diagnosis of diabetes. And that's usually, to help, lower those blood sugars. And especially if they have other risk factors, if potentially like someone is like overweight, or it has other like family history of diabetes, they may start somebody on that medication. And that's just really to help the naturally occurring like insulin that your body makes just function better to help lower your blood sugar. So it's usually like a shared decision making between your doctor and the patient, whether to start that or not. But usually they just may start somebody on metformin to prevent any like if they have any like risk factors or family history or something like that before actually being diagnosed with diabetes.
Thank you for that.
Yeah. All right. So let's get into a deeper dive of metformin. So metformin is, one of those medications that we start, it's probably one of the first medications we start patients on when they're first diagnosed with diabetes. It's a medication that's been around for quite a long time, and it's very safe and effective in lowering our blood sugars. And so how it works is it helps that insulin that our pancreas makes in our body function better. It just helps the insulin become more sensitive and helps to lower your blood sugar. It also lowers the amount of sugar that your liver produces or pushes out into the body, and lowers the amount of sugar your intestines absorb as well. So it's a great medication to start patients off on because it's generally very well tolerated, not too many concerning side effects. The only thing to really note about this medication is it can cause some stomach upset, such as like nausea is very common, diarrhea. It can cause vomiting if, the stomach upset is severe enough. And so usually what I like to tell patients if they are having that kind of stomach upset is to take the medication with a meal or with some kind of food when you do take it to kind of help with to reduce those stomach side effects. In addition, there's kind of two forms of metformin you can get. One of them is like an immediate release, and the other one is an extended release. And the extended release formulation usually helps to reduce those side effects as well. So overall, this medication is one of the first we put patients on because it's generally very affordable. It is effective at lowering our blood sugar. And it's generally well tolerated except for that stomach side effects that it can sometimes have. So that's just a little bit about metformin. Usually one of the first we usually go to for um, medication selection for diabetes. And so now for some of the medications, sometimes we have patients in the clinic that ask frequently asked questions. So I kind of wanted to see if we can do like a true false kind of game with everyone for certain medications. So there's some questions for metformin here, true or false. And so the first one is, does metformin cause any kidney damage? Do you guys think that's true or false?
Fault?
Yeah, exactly. Um, Hold on. Yeah, so that question is false. Metformin doesn't cause kidney damage, and it's not a side effect of metformin. Usually what can happen in diabetes over time is that if somebody has had diabetes for, over a long period of time or like decades, or if somebody has had very uncontrolled or high blood sugar of diabetes for a long period of time, what can happen is that that high blood sugar can damage our organs over time. And so one of those is the kidney, as well as like it can also damage like our heart, our nerves, things like that. So metformin is not a cause of kidney damage. But it is, if someone does have kidney damage, it's always a good idea to let your doctor know so they can appropriately dose for the correct dosage of this medication. Alrighty, the next question, does metformin cause liver failure? What do you guys think? True or false?
False.
False.
Yes, thank you. So yeah, this question is false. Metformin doesn't damage your liver. And if anything, metformin can actually be used for patients that do have any kind of liver damage already, such as like mild or moderate liver damage. It's also safe to use in those kind of cases as well. So no, metformin doesn't damage your liver. All right, so getting back to our next class of medications, these are we normally call them TZDs. And how it works is it helps our body respond better to insulin. It's just a once a day tablet, and it's overall very well tolerated. The only thing to look out for is we wouldn't want to use this medication for anyone with heart failure because it can cause like some swelling of the legs or edema. And we especially don't want that for our patients with heart failure. But some medication in this class you may be familiar with is pioglitazone, also called Actos or rosiglitazone. Overall, this medication is very well tolerated and can reduce our A1C by about 1 to 1.5%. All right, and then our next medication class is called SGLT2 inhibitors. These have been kind of come out in the past like decade or so, and they're all still brand name drugs, so they can be a little expensive if insurance doesn't cover them. Some of the names in this class are Jardiance, Farxiga, and Invokana you may have heard of. And how this medication works is that it helps to lower the amount of sugar your intestines absorb, and it also helps to get rid of the extra sugar in your body through your urine. So because of this medication, it can cause some increased urination. So I always like to tell patients to take it in the morning so it doesn't really bother you with, using the bathroom during the evening when you're trying to sleep. Also with this medication, since it kind of helps the body get rid of the extra sugar through your urine, it can cause an increased risk of any yeast infections or urinary tract infections. So always, practicing good hygiene while on this medication. And then lastly, since this medication can kind of make you pee out that extra sugar, it has that diuretic effect. It's really important to make sure to stay hydrated on this medication because if somebody doesn't drink enough fluids and they get dehydrated, something that can happen is called euglycemic ketoacidosis. And what that means is it kind of can make our body go into more like an acidic state. And so if anyone does get sick on this medication, we always tell our patients to stop taking it while you're sick, just to prevent any dehydration and any dehydration, or also preventing your body from going into that too acidic state while on this medication. Other than that, you can also see on this slide that there are a lot of different benefits for this class of medication. Some of the benefits that it has is it has some kidney protection. It also has some benefits for heart failure. And of course, it does a great job at lowering our blood sugars. It also has cardiovascular protection, so decreasing risk of like heart attack and stroke. And because it has that diuretic effect, it can help lower our blood pressure too a little bit. So overall, this medication has a lot of benefits. It's one of our newer classes of medications, and it's a tablet that someone would take every morning. And so, yeah, it does a great job at lowering our blood sugars by getting rid of it through our urine. Any questions about this class of medication or anything I've gone over so far? Okay. If not, then we will continue with our next class, which is our sulfonylureas. Some of you may have heard of these medications, and some of the names in this class are glipizide, glimepiride, and glyburide are the most common ones. And how this medication works is it's very effective at lowering our blood sugar. Basically, it makes our pancreas kind of release more insulin. I will say, even though it is an effective medication to help bring down our blood sugars, this is not necessarily a medication we like to keep patients on for a long period of time because it can kind of tire out our pancreas after a while. And some way you can kind of think of this is you can kind of think of our pancreas as like a sponge, and this medication is kind of like wringing out our pancreas or wringing out that sponge to help release more insulin from our pancreas. And so over time, after it keeps like squeezing our pancreas and getting that insulin out, the effectiveness can decrease over time, and our pancreas can kind of get tired after a while and not work. It kind of loses its effectiveness over time. So we try to not keep this medication with patients for too long, even though it does do a good job at lowering our blood sugars. And because of its effectiveness of decreasing our blood sugars, it does have a higher risk of hypoglycemia or lowering our blood sugar too much. So, when on this medication, we always like to emphasize with patients to always check your blood sugar when you feel off, especially if you are having any symptoms of low blood sugar like shakiness or sweatiness. Making sure to always check it when you feel off. And if your blood sugar is under 70, making sure to treat that with, some kind of something sweet, just like regular soda or some juice to help bring your blood sugar back up. But yeah, so this is sulfonylureas, a medication that is very effective at bringing down our blood sugar, but the effectiveness can decrease over time. So something to keep in mind when starting on this medication. All right. And our next class of medications are our DPP-4 inhibitors. And some medications you may have heard of in this class are Januvia. It can be also Tradjenta or Onglyza are some of our common ones in this class. This medication just works to help your pancreas release more insulin and be more effective to lower our blood sugars. This medication is taken just once a day, and it's not our most effective medication at decreasing our blood sugars. As you can see at the top, it only reduces our A1C by about 0.5% or maybe 0.7% at most. So it's a very well tolerated medications, not many side effects to note for this one. The only reason why we wouldn't use it is if somebody has had pancreatitis in the past. We wouldn't want to use this medication in those patients, but other than that, it's very well tolerated, and it's just usually a medication we may add on to other oral tablets used to lower our blood sugars. Alrighty, so I know there's a lot of words on this slide, and I think this slide is important because it talks about one of our more popular classes of medications. The official name is our glucagon-like peptide or GLP-1 receptor agonist. And I know some of you were interested in hearing more about this because some of the medications in this class are Ozempic, Trulicity, Victoza. Those are some of our brand named of medications in this class. And this class has definitely increased in popularity over the past few years because not only is it very effective at lowering our blood sugar, as you can see there, it can have a decrease in our A1C of at least 2%, but it also has a lot of great weight loss benefits that have gained a lot of attraction and interest in the news over the past few years. So how this medication works is it helps your body release insulin when needed. So unlike our sulfonylureas that I talked about before, it's just going to tell your pancreas to release more and more insulin, no matter whether you've eaten a meal or anything sugary or not. This medication is really smart on how it works because it only tells your pancreas to release that insulin when you've eaten a meal or when your blood sugars are high. And so because of that, it has a low risk of hypoglycemia or making your blood sugars go too low. Another way it works is it helps slow down your stomach and how quickly your stomach empties, and it also makes you feel fuller longer. It also kind of communicates with your brain to tell you that you're full as well. So kind of going along with that, it does have that weight loss benefit because it kind of talks to your stomach and makes you feel fuller. So some patients feel like they don't need to eat as much in order to feel that to feel like they're full. Some other things to keep in mind is it does have some stomach side effects like decreased appetite that kind of goes along with the weight loss. Also nausea, diarrhea, constipation, and sometimes vomiting as well can happen on this medication. And usually what I've, heard from patients is usually these side effects will kind of go away after a few days after your body starts to get used to this medication a little more. And I always try to tell patients they can try eating smaller, more frequent meals to reduce that nausea compared to if they were to normally eat their larger meal during like dinner or something like that. Some other side effects that are more rare is if if somebody's had gallbladder inflammation, we would want to avoid this medication, and especially if they've had pancreatitis. And these are all rare things, but if anyone does have any severe abdominal pain, it's always important to go seek care for that. And just like our SGLT2 medications, these class also has a lot of benefits. Not only does it help with it's very effective at lowering our blood sugar and can have that weight loss benefit, but it also has some protection for our kidneys and protection against cardiovascular disease too, kind of reducing the risk of heart attack and stroke. So yeah, I know there's a lot of information on this slide. Does anyone have any questions about any of these medications like Ozempic, Trulicity, Victoza? Anything else I can answer for you guys?
Hey Julia, my name is Karen. I have a question on the Ozempic.
Mhm.
So my sister has been using that for a while now to manage her diabetes, and her A1C went from like 11 to like 5. But she's been having some issues with it, and I keep telling her it's probably might be related to that. So for her, she had her gallbladder removed. So would that even be a concern for that?
Yeah, that's a great question. So actually, this medication has the potential to cause like gallbladder inflammation, but if somebody has already had their gallbladder taken out, then we're not worried about any of those gallbladder symptoms anyway, because since those patients don't have a gallbladder, so it's completely safe if somebody has had their gallbladder removed and would not be a reason, not to use this medication. So that's totally fine. And then regarding those side effects, side effects can develop, not only at the beginning when first starting a medication, it can happen later on, or especially if we're, increasing the dose of this medication. Um, so for that in particular, if it's something that's very bothersome for a patient, there are sometimes we may, try other options as well. If it's something they just can't tolerate, if they're having a lot of nausea or vomiting, just because somebody doesn't tolerate, one medication in this class doesn't really mean they won't tolerate, a different one. So for example, if somebody's on Ozempic, I've had, some patients that have been on a medication, but, switched to a different one. And, they didn't have any side effects with that medication. So I would say if someone is kind of struggling with side effects on a medication, but are still getting those benefits from it, just seeing if maybe they could, if their insurance will let them try a different medication, and seeing if those side effects get any better from a different medication in that class.
Okay, got it. Yeah, just because seeing her go through that, I'm like, I know Ozempic was offered for me, but I said, I think I'll wait. Okay, thank you for that.
Yeah, no problem. And yeah, we usually just start at the lowest dose for these medications, and we'll titrate them up slowly just to make sure patients are tolerating it okay. But yeah, I would make sure to tell her to let her doctor know about that so she can kind of see like what other options are there for her out there.
Okay, thank you.
Yeah. All right, so so kind of going along with the true and false questions, I have some for our GLP-1 receptor agonists, and these are the ones in the class for like Ozempic and Trulicity, that sometimes we get asked in the clinic from patients that I wanted to go over with you all today. So my first question for you all is, do you think that GLP-1s, do you think they cause thyroid cancer? Have you heard of that? And would you say it's true or false?
False.
Yeah, exactly. So, this class of medications, let me go there. Yeah, so this is false. There hasn't been any evidence to show that this class of medications causes thyroid cancer. There have been some studies that have shown it may cause some thyroid cancer in rodents, but it hasn't been proven in humans at this point. There's just been no clinical evidence to show that. So this medication is safe and doesn't cause any thyroid cancer. If somebody or anyone has a history of thyroid cancer in their family, we may try to avoid it just to be on the safe side. But there hasn't been any clinical evidence to show that these medications cause thyroid cancer in humans. All right, and then my second question is, do these medications, do this medication cause stomach paralysis?
What is stomach paralysis?
Yeah, great question. So stomach paralysis is kind of a term that's also called, I guess in the medical field, it's called gastroparesis. And that's just a term where our stomach kind of just slows down to the point where it's very slow at digestion. It's very slow at digesting and just takes a long time to digest our food. And so yeah, great question. And for this medication class, they don't cause stomach paralysis. And I think where the confusion sometimes comes with this medication class is that these GLP-1 RAs like Ozempic and Trulicity, they have the effect on the stomach to kind of slow down our digestion a little bit and help you and make you feel fuller longer. And it kind of communicates with your brain telling you that, you feel full with eating a smaller amount. But no, this medication doesn't cause, complete, stomach paralysis. And so if anyone, does come into our clinic and already has that diagnosis of gastroparesis, we would not start, that patient on this medication to not make anything worse. But no, in general, there's no evidence to show that this medication class causes an increased risk of stomach paralysis. All right, and then let's see, before I go on, any questions about what I just went over? Any clarifications? Okay. So if none, now I'm gonna kind of shift and go into more insulin. And so this medication, I'm not sure how many of you have questions about it or maybe taking it, but just to give you an overview of how it works is insulin is very effective at lowering our blood sugars. Insulin is probably the most natural medication that we have because it mimics almost identically the insulin that is produced from our pancreas. And so, how insulin works is it helps your muscles and fat cells take in more sugar from your blood and reduces the amount of sugar that your liver makes. So I'm going to be talking about like the two main types of insulin that we normally use in the clinic. And one of them is a long-acting insulin. This insulin, lasts throughout the whole day, and it's injected either once or twice a day, depending on the agent. Some examples in this class are Lantus, Basaglar, Toujeo, Levemir. Those are some of the common names that people may hear if they're on a long-acting insulin. And then we also have our mealtime insulin. And some of the names in this class are like Novolog, Humalog. This medication is injected before meals, usually about 5 to 15 minutes, depending on the medication. And it's used to help lower our blood sugars from that meal specifically. So if we're starting somebody on insulin, we'll always start somebody on a long-acting insulin and kind of see how they do on it. And we'll titrate and increase their dose if needed. If somebody has been on long-acting insulin for a while and we notice that, their blood sugars are still high, especially after eating a meal, we may add on a mealtime insulin. So they'll take that insulin that's shorter acting with the meal to help reduce those blood sugars from the carbs and the sugars we eat from that meal specifically. So with this medication, it can cause some weight gain. And insulin is also very effective at lowering our blood sugar. So it does have a risk of hypoglycemia or pushing your blood sugars too low. So it's always important to check your blood sugars, especially when on insulin, to make sure that the dose is correct for you and to make sure that we don't need to make any adjustments if it's we don't want your blood sugars to go too low. We also don't, if they're too high, we may need to increase the dose. So always making sure to check your blood sugars, especially whenever you feel off or you kind of feel, kind of shaky or sweaty. That would be a good time to check your blood sugars. All right, so going into some true-false questions about insulin. And some of the questions we sometimes get in the clinic is, does insulin cause kidney failure or dialysis? True or false?
False.
Yeah, exactly. So, how this question kind of comes around with patients is sometimes they'll see patients that when they're started on insulin, sometimes they have like worsening kidney function, or they'll see them on dialysis. And insulin is a safe medication, and usually it's the only medication we can use if somebody is on dialysis because it's safe for the kidneys and it's not going to cause any kidney damage. And sometimes another perception and something to keep in mind is, kidney failure and kidney damage is something that can happen naturally with the progression of diabetes, especially if somebody has had diabetes for a long period of time or have had uncontrolled blood sugars for a while as well. So no, insulin doesn't cause any kidney failure or dialysis, but it is usually the main medication that we would use for dialysis because it is safe for our kidneys in that sense. All right. And then another question sometimes we get asked is insulin addictive? And what do you guys think? Is this true or false?
False.
Yeah, exactly. So insulin is not addictive in the sense of like any other drugs of abuse. But sometimes how this can be perceived and why some people may think this is because sometimes when patients are started on insulin, they may be continued on it for a long period of time or maybe even for the rest of their lives. So it can kind of be seen as like if, once somebody's on insulin, it's, hard to discontinue it. And not just maybe because sometimes insulin is added on later in somebody's regimen, after they've already, been on other oral tablets, and it's something that's sometimes added later on in their regimen. And so over time, our pancreas and diabetes can kind of tire out and not be able to keep up with the insulin demand that our body needs in order to lower our blood sugars. And so sometimes insulin is needed to kind of help supplement our pancreas and giving our body the insulin that it's looking for in order to help our blood sugars. Um, so insulin is not addictive, but it can be a nice tool for us to kind of help out our pancreas and lower our blood sugars. And sometimes over time, our pancreas can get worse, especially in diabetes. And so sometimes that dose may need to be increased over time. So it's not necessarily addictive. It's a really helpful tool to help our pancreas out and give our body the insulin that it needs to help lower those sugars. Okay. And next question, does insulin therapy mean my diabetes is bad? Is this true or false?
True?
Um, That's a good guess. And yeah, we'll kind of go over that because I think that's a really common perception of insulin. People think, if they're put on insulin, their diabetes must be really bad or getting worse. And that's not necessarily true, because there are a few different instances where we may use insulin therapy. And one of them may be, when somebody is first diagnosed with diabetes. Insulin is very effective and brings down our sugars very quickly. And so sometimes it may be the first medication we put somebody on, especially if they're having symptoms, their blood sugars are very high, and they're not feeling very good. Insulin is a great way to bring down those blood sugars as fast as possible so people or patients start feeling okay from those high blood sugars. And another instance where we can use insulin is, if we don't use it at the beginning of somebody's therapy, we may, need it later on. And usually we like to kind of hold off on insulin because it is an injection, and a lot of patients, it can be a life change to start those injections every day. So we like to, try to give patients a break and put them on some kind of oral therapy if possible. But sometimes we may need to eventually add on insulin if our oral medications are not kind of doing the job right and bringing down our sugars. So it's not necessarily that insulin means that your diabetes is bad. And usually, especially kind of the changes in our guidelines, is they kind of recommend insulin earlier on if possible to kind of help prevent those complications from diabetes, because insulin is very effective at bringing down our blood sugars, and it can help bring them down a lot faster than a lot of other medications can. So yeah, great, great question, great perception. Hopefully I answered kind of some of your questions and thoughts there. And lastly, my question for you guys is, does insulin cause weight gain, true or false?
Fault?
This one is actually true. It can cause weight gain. And that's just because insulin, it works in our body to kind of, store some of our sugars into our muscle. It can store it in our liver. And another way that insulin can store that blood sugar is into our fat cells. And insulin can increase weight gain over time, especially because if, insulin keeps storing that extra blood sugar that our body is not needing, it can kind of build up over time. especially if somebody is consuming more calories than your body needs for energy, and it keeps, putting that into our storage, into our fat cells, and our body is not really burning that or is not using that energy, it can definitely build up and cause weight gain. So yeah, that one. So yeah, that one is definitely true. And then any questions about any of the true false questions I just went over with you guys? Okay. If no questions, I'm not sure how many of you are familiar with insulin, but just wanted to show you in case some people in the audience were kind of curious what it looked like or how to use it. I'm just going to show you an example. And let me stop sharing my screen here. Of example of like what an insulin pen looks like. And this is kind of what the pen looks like. This is where the medication is kept. And then there's a little dial here where you would dial up to your dose, and then you would press that button down to inject it. And I also just wanted to show you, what the needle looks like as well, because I feel like a lot of patients, when they're first or they're kind of thinking about, whether they should use insulin or not, a lot of them are kind of worried about the needle and kind of worrying about that injection. Um, so this is kind of like what the pen needle looks like, and you would just kind of twist it on the top here. And there's an outer cap and there's an inner cap, and then you can see there's a tiny, tiny needle right there. And you can kind of see it's, my screen's kind of blurry, but it's actually a lot smaller needle than people would expect. So a lot of the times, it's actually not that scary than people kind of make it out to be. Okay, let me get back to my slides here.
I have a question, Julia.
Go
Can you
ahead.
tell me how many doses are in that pen?
So, it really depends on what you're taking every day. I will say in a box that you get, there's like 5 pens in a box, and that's about 1,500 units. So it will likely last you at least a month, depending on, how many units you're using a day and kind of how that looks like. But whenever you are given insulin, your provider will make sure you at least have a 1 month supply whenever they give you insulin, so you're not running out super quick. Okay. Any other questions about insulin?
Yeah, I have another question. I know that our rates of our incidence and even prevalence of diabetes among the American Indian population is pretty high. And I know I read some articles where it's attributed to non-compliance with medication. Why? I mean, is the need? Do you know why patients would not continuously use the insulin prescription?
Yeah, I think that's a great question. Um, and something that, you would think, insulin is it's a great medication to help bring down our blood sugars. Like, why would somebody not want to be compliant to it if it's helping them? And I think really what it comes down to is, really depends on the patient, but oftentimes I hear from patients that, having those insulin injections can kind of be a burden on their on their daily life, and some people just don't enjoy kind of giving them injections every day. And I do understand it's a big lifestyle change for somebody to make, to having to go from taking their, pills every day to having doing an injection. Some patients just don't like that, or um, you know, just don't appreciate that they have to poke themselves sometimes a few times a day. Um, so I think, that might be the reason, just like not, just kind of being frustrated and, just being frustrated with diabetes in general, which is totally understandable. So I think it really depends on the patient and their motivation and how willing they are to bring down their blood sugars. But I think that's a great question. And we'll definitely, in the next section, we're going to be talking about like medications and how to help remember taking your medications on a daily basis too.
Hey, Julia, if I could jump in on that one. Um, Hi everyone. My name is Becky, and I work with Julia over at North Country. And prior to this, I spent many years working in the IHS. And I would say that that's like the $1 million question, right? Is how do we get our indigenous populations healthier? And man, if I knew the answer to that, I just think that I think there's so many factors that go into that. Like we have some patients who don't have a refrigerator, so they can't store, insulin long term. It's like a major problem. That's a major problem. Just straight up access, trying to get to the clinic just to pick up their refill. Transportation can be a huge barrier for a lot of those patients. I also think that there's a lot of stigma around some of these medications, and I'm really glad that Julia did that whole kind of true false thing to sort of kind of touch on some of those the biggest ones. Like what I hear a lot is I don't want to start insulin because my grandmother was started on insulin and then she ended up having a toe amputated, or my grandmom started insulin and then she had to go on dialysis. And so they associate the initiation of those medicines with the progression of the disease, um, when in truth we probably should have started those medicines along a lot earlier to prevent the disease of diabetes from progressing to the point of an amputation or a kidney disease, advanced kidney disease. Those are like some of the, I think, just barriers to, if we're talking just about compliance. Honestly, I don't I don't think that non-compliance to medications is causing um in our indigenous populations to have diabetes. It may be causing it to progress though faster than it would in other communities. Um, I hope that makes sense. Okay, I'll turf it back to you, Julia. I just want to put my 2 cents in.
Yeah, thank you for speaking on that. That was really valuable. Thank you. All right, so I know we have just a little bit of time left, so I'm gonna hopefully try to speed through this and get through everything. So just to go over injection areas of insulin or our injectable medications, it's generally going to be our stomach, the most common area. Some other places you can inject these medications is in the outer thighs or the back of the arms as well. And lastly, my last point I wanted to kind of go over is how to help patients remember taking medications. And I kind of wanted to, I don't know if we have time to kind of ask you guys, the audience, what are some of your ways to help you remember taking your medications? Is there any certain method or something that helps you remember to take them that you could share with the audience?
I usually take mine first thing in the morning.
Okay, awesome. It's a great way to remember first thing in the morning just to get it out of the way. Anyone else have any tips, tricks?
Hi. A lot of our patients, I noticed like the 7-day like pill containers, and especially the ones that are split into like a morning and a nighttime with like a sun and a moon or something. I think those are really helpful. And also, a couple years ago we did have like a diabetes expo, and one of the prizes we gave out was like a medication, like a pill holder that had a timer on it, or you could like set an alarm on it. So it could notify you when you had to take your medication. And then also it would help you remember if you had already taken it that day. It wouldn't let you open it again until like it was time for you to take it again.
Oh, wow, that's a really cool device. I've never heard of that myself, but I think that's so helpful, especially for patients that have trouble remembering if they have already taken it or not taking it. That kind of device to let them know if they've already taken it, they're done for the day and gives them those alarms. I think that's such an awesome device to have. That's really
Yeah.
cool. So just a list of things that I kind of came up with, and I know some of you already mentioned a lot of these, is like you already mentioned, just the pill box and just setting out your pills for the week and just kind of seeing, so you can kind of remind yourself if you have already taken it or not. It's kind of just a good way for you to keep on track, especially if patients take multiple pills a day. We also talked about this too, but maybe setting an alarm, especially on your phone, if you take all your medications at a certain time of day, just having that alarm go off every time that day to kind of give you that reminder that it's time to take your medications. I also think, if you're able to store them in a visible location, so somewhere maybe on your kitchen table or something like that, whenever you eat your meal, kind of gives you that reminder like, oh, I'm supposed to take these medications. I haven't taken them yet. Um, or we also have other apps that you can try that I kind of learned about when doing this presentation, called like My Pillbox or MediSafe. These are just free apps that you guys can try if you're interested to kind of put all your medications in there and set alarms and kind of remind you to take them and what time to take them as well, which I think was pretty cool. And I think just pairing with other habits too, like taking it the first thing in the morning just to be done with it for the day, or kind of if you're having a cup of coffee, just kind of a reminder of doing that and taking your medications. So with pairing it with other habits can also help too if you do those habits consistently. And I would say for injectable medications, usually they need to be kept in the refrigerator for most of them. And if that is something that's been a struggle for patients, a lot of those injectable medications can actually, once you start using it and opening it, um, after you've kind of started using that pen, most of them can be kept out of the refrigerator for about 28 days or about a month or so. So if someone's having issues remembering to take their injectable medications, they can actually just leave it out on the counter if it's something they've started to use to help with those, so they can visually see it whenever they walk by to kind of as a reminder to help take them if that's kind of an issue. And lastly, the last thing I wanted to mention, if patients are having any side effects, just make sure to let your doctor know before stopping a medication, especially if you're having any troubling side effects. Your doctor would really appreciate knowing if you're going through something or if you're having a really bothersome side effect so they can try to think of alternative options that may work better for you. So instead of just stopping it, let your doctor know so they can try to think of an alternative that may work better for you and help keep your sugars at goal. All right, so thank you so much for your time today. I know I went a little bit over, but I appreciate your guys' questions and your insight and your participation today. If you guys do have any questions about